All right. Hi, everyone. It looks like it's 9:30, so I think we're going to go ahead and get started with our Advancing Health Equity session, and we're going to give it over to Dr. Miranda Ward.
Thank you so much. So I'm going to go ahead and start sharing my screen. Hopefully you can see this. Let me know if you can't. I'm really excited about the opportunity to speak with you today. Today's topic is advancing health equity, addressing disparities, and promoting inclusive care. So my name is Dr. Miranda Ward, and I'm an assistant professor and director of equity in the Department of Clinical Research and Leadership, which is at the GW School of Medicine and Health Sciences. And I've been in that role since 2017. And I literally design and teach health equity. So I look forward to, I was told that we have some of you who have joined this particular breakout who has already either been working to advance health equity, you believe in health equity, you are trying to learn more about health equity, so you are in the right place, okay? So in particular, I wanted to share that I don't have disclosures, but I did want us to jump right into an activity before we move into the objectives that you will be able to meet and then earn your continuing education credit. So typically I like to, have you go into a breakout room with a partner or two, but because we're already in a breakout room, you're just gonna do this individually, okay? So what you see here is not an exhaustive list of all of the factors that impact and shape our life expectancy, but it's a pretty good start of the factors that do. So what I'd like for you to do is to look through this list and what would you say of all of the things here, type of occupation, individual behaviors, genes, income, neighborhood, education, access to healthcare, economic and racial inequality, and influence over government and corporate decision-making, what would you say is the number one most important factor that actually shapes life expectancy? And what's the least important, the number 9, okay? So in the chat, you can just put 1 equals whatever characteristic, and then 9 equals whatever characteristic. So I'll allow for you to get some time to kind of think through, and then you can just go ahead and join and add your thoughts to the chat. So neighborhood, characteristics, education, and okay, it's all over the place. All right, so you know what? Let's go ahead and start with access to medical care. And so, one of the whole topics of today's discussion is really thinking about inclusive healthcare. And what if I told you, though, that 20% of what impacts our health outcomes is actually healthcare? The other 80% is everything else. Is that shocking or surprising to anyone? Because if you think about it, the average person does not live in a clinical or hospital setting, right? We know some people do, right? But the average person does not. So that means that the other 80%, all these other factors, not just healthcare, are literally contributing and weighing in on your life chances, right? So that's one thing to consider. And again, we are going to talk about healthcare because access to healthcare is more than just geographical access. It's more than financial access, right? Those are two really important aspects of access. But we also have to think about navigational access. You know how we talk about patients falling through the cracks? Absolutely, because it's a unnecessarily complex, nuanced, system. So navigational access, but there's language access, there's cultural access. So access very much includes so many different factors. But if you think about it, it really isn't the most important. And again, I realize that this is probably going to be a very subjective type of activity. For those of you who are saying, I actually appreciate that nobody included genes as number 1. Okay, so we're in a good place, okay? Because I will say that depending on when this question was posed, like back in the day, people probably would have said genes, right? Like I just inherited this, right? But what we know about genes is that genes most certainly interact with the environment, right? They're not static as we once thought. So they, the expression of our genes change as we, are in contact with toxins and pollution and stress and our nutrition. So I definitely appreciate that some of you even noted it was the least important. Okay, so thank you for that. But then also some of you just didn't even include it, so shout out to Sheila. All right, now a good number of you have been talking about neighborhood and income. What if I told you that there actually have been recent studies that when we think about, for instance, maternal mortality, you already know, right? And this is not news, that the United States has the highest maternal mortality rate of all industrialized nations, right? And so, our peers like Austria and Finland, right? They have, the number of maternal deaths is 3 or 4 out of, every 100,000 live births. In the United States, it's 23, right? So it's kind of like a whopping difference. But specifically for Black women, it's 3 to 5 times higher than that, right? And depending on where you live, that's why I say 3 to 5, because it's 5 times higher if you live in DC, because that rate actually goes from 23 nationally to 70.9 if you live in DC, if you're a Black birthing person in DC, which is unconscionable. But there actually have been studies that shows that, actually income and, education aren't the protective factors that we once thought they were, right? There's this idea that, oh, all you got to do is get prenatal care and you should be good. But remember, it's not just access to medical care. We talked about that, right? So Black women actually, we already know Black women just as a group have the higher, levels. But it's actually Black women with more education, with more, income that actually fare worse than other Black women. So we also have to look at within group differences, right? So we have this tendency to only compare Black women to white women, Black women to other women. No, Black women within Black women, right? There's a subgroup of Black women that actually fare worse. And those are the ones that have the high income and have the education. And we thought those were protective factors. Why do you suppose, and feel free to raise your hand or put into the chat, why is it that they actually are worse? And they got the high income, right? they can see, they obviously have healthcare, right? Private insurance. They go and see Leah. Basically, she nailed it on the head. Thank you so much. Absolutely is stress. And that is what, Arlene Geronimo, the weathering hypothesis really comes in. And it's not just any type of stress, it's racism in particular. So we have to name things for what they are, right? So if you think about the Black women who have the high income and they're in the C-suite and they, are in these kind of high paying jobs, they're more likely to be in white dominated spaces. And so that level of racism that they're experiencing is that much more pronounced, and it literally weathers or biologically ages their body. And so now, because if you think about birth, it's already a stressful event, right? And then so now you add the ongoing enduring stress of going through racism. And again, you could look at that intergenerationally, a Black grandmama going through chattel slavery, that, and then pass down that change genetic expression to the Black mama who went through Jim Crow, and then now the Black, this Black mama who's, going through like state section violence, right? So again, no matter which generation they're born in, and the form of racism, is still pervasive and looks a little bit different, but nonetheless, it definitely shows up in that way. So thank you, Vanessa, for noting how, they're not believed, right? They are, they are weighed against tropes as angry Black women, right? They're aggressive because they're speaking up and they're trying to advocate for themselves, and then that actually backfires, right? So there's lots actually written on this. So I do appreciate each of you kind of weighing in on this activity to just, provide some context for the discussion. Because what we really want to do is we really want to explore what is health equity, right? I mean, we all use the term, but there's really no universal shared understanding of what it is, how to measure it. So let's have that discussion, because that is going to be important for you as, practitioners in the primary care setting. And ultimately, we really have to know, like, at the root of disparities are inequity. So we have to talk about the different structural drivers of the social determinants of health that contribute to those disparities. And ultimately, hopefully we'll have enough time to really kind of think through some strategies. And I want to hear from you, right? So it's like, I don't have the end all be all the strategies that's, that promote health, but, I'm sure that many of you have been really kind of thinking through some of those strategies. Maybe you've had some wins and you like to share. So let's go ahead and start off with Healthy People 2030, right? And as we know, every 10 years when the census comes out, we update our goals, right, for the decade, right? Started back in 2000, well, the 90s actually, looking ahead to the year 2000, recognizing that, you know what? we never thought that, health disparities weren't a thing. As you can see, we named the, health disparities exist and, amongst Americans. So we probably should, work to reduce them. But then we wised up and realized that that's not a lot, that's not an aim, right? You don't aim to reduce disparities because that means that we're okay with them, being remaining in some capacity. We should work to eliminate them. And then the reduction is actually an indication of progress, right? But by 2020, that's when you see the language changed. Not only do we want to eliminate health disparities, but we want to achieve health equity. So that just lets us know right now that health disparities and health equity are obviously not one and of the same. Because we said we want to eliminate disparities, but we want to achieve health equity. So that's the first thing. We know that we should stop. For those of us who use those terms interchangeably, they're not the same, right? They are interconnected, but they basically they stand on their own. And we also want to, by 2030, we want to still, achieve health equity, eliminate disparities, but we now really also know that you can't do any of that if you don't have a health literate, population. So let's think through this definition. Feel free to just use the chat. You can put a 1 if you think this first definition is the way that you think of health equity as this fair, just opportunity to be as healthy as possible. You can put a number 2 if you think about, no, actually health equity is about removing obstacles, right? Whether those are, social, cultural, geopolitical, economic, and, and there are a range of obstacles and barriers, right? If you feel like it's probably something, it's not either of these, right? I don't know what it is, but it's not this. You can put 3. And then if you think it's something else, feel free to put 4. Okay. So if you put a 1, well done, right? Absolutely. Health equity benefits everyone, right? When we talk about health equity, we're not talking about one specific population or just these particular populations. We're saying everyone benefits from health equity. And we recognize that, when we say, be healthy, being healthy is very relative, right? Because what's possible for me and my health is going to be different from somebody else, right? Not just because of, maybe developmental reasons, but biological reasons. So yes, genes do play a role in that, right? What's biologically possible for me, just given the circumstances that I have, biologically. And so, but whatever is possible for me, right, biologically, I should be able to achieve that. So we want to remove any social reason that you're not achieving what's optimal for you, right? So again, the biology, we can't change it, right? So, but that's what we're saying. We want to make sure that there's no social reasons why you're not, where you need to be for your biology. Now, for those of you who chose number 2, you're also right? Because this first one is basically a normative concept of what ought to be. And so it's the outcome that we're looking for. But, removing barriers, naming the barriers, identifying the barriers, removing them, that is a process. That's how we get to that outcome. And so that's equally important. And we have to recognize that there are social reasons why people can't get to their biological optimal health, right? But I will say that we also have to think about, so again, you said 1 or 2, you're on it. For those of you who said 4, I don't think I've seen any 4s in the chat. Do I see any 4s in the chat? Oh, I do. Thank you, Kendall. Okay, so another definition, which is a technical definition, and this is a really helpful definition because while you have the, this kind of lofty, everyone achieved their fullest health potential, how do you measure that, right? This is how you measure it. So this is how both health equity and health disparities hang together, because the presence of disparities lets you know that you have not achieved health equity, right? So any reduction in health disparity is an indication that you're getting closer to health equity. So this is why it's really important to understand what those social determinants are, because again, those are the determinants that are literally affecting all of our health, no matter again, so there's this misnomer that when we talk about the social determinants of health, we're only talking about socially disadvantaged groups. No. Everybody is affected by housing, right? It works favorably for some, and then, it could work adversely for others, right? But nonetheless, the factor is housing, and that's the same, no matter who you are. Same thing with the neighborhood and built environment, same thing with food access, right? The same factors, but sometimes they just work to improve and advance your health, and other times they don't. This is why, I wanted to just kind of pull together all of the concepts so you see how they're mutually reinforcing. I like to think of these as framing language, like I said, just because there haven't really been any kind of universal understandings of these concepts, but I think it's helpful for us to try to wrap our mind around a really good way to kind of think about that. Because again, ultimately, we do want to achieve health equity, right? And we recognize that one of the ways that we measure it is an empirical measure we call health disparity, right? It's a population health statistic that we actually use because disparities, disparities do not exist in individual people. You don't have a disparity. I don't have a disparity, right? Like I said, it's a population health metric. So entire groups have a disparity because you compare one group to the next, right? So we use the epidemiological data to assess that. And that's just the thing. It just tells us what the difference is. It doesn't tell us why. Health inequity tells us why, right? The structural reasons, right? Mass incarceration, poverty, racism, right? Gender oppression, heterosexism, right? The big macro issues, those are inequities. And that is the reason why the groups that are experiencing health disparities experience the disparities they do, right? Because disparities are unnatural. There's nothing, it's inevitable that there's going to be health differences, right? And so health disparities are, there's no biological basis for them. And so we know that the only reason they exist is a social reason, which are the inequities. And the way to achieve health equity is through a social justice approach. So again, let's go ahead and take what I just said and actually let's apply it in practice. Okay, so let's see. Okay, we just talked about how these all hang together, what the disparity is. So let's just do a quick little practice. So which of these do you feel like? Is it all of them, two of them, one of them, none of them? Okay, I'm gonna read through them and you can put into the chat. A, B, A, C, B, just A, just C. You can put into the chat. So if you believe that a health disparity is a person that has a rare blood disease that becomes chronically sick and at risk of premature death due to unavailable treatment modalities, if that is a health disparity, you can put A. If you feel like, well, it's Black women dying of breast cancer despite having a lower number of new cases than white women who survive breast cancer, then you can put B. If you think it's C, well, there are higher rates of long bone fractures in skiers in comparison to non-skiers. So again, do you think it's A, B, and C, just C, just A, B, and C, A, B, right? Just whatever iteration you believe. Okay, so the majority of you said B, and we do have a couple of A's, and we have, I think I only see one C. Okay, so does anybody want to unmute themselves who actually said A and share why you believe that A would be an example?
I can go.
Okay, great.
So I put A because it said that really towards the end to me was the clue that unable due to unable treatment to me when I seen that is access, and it said that health disparities and then being in this space, it's really just about making sure that everyone has a just for getting health care. And that stood out to me more than the other two.
Okay. Oh, so you just chose A then?
Yeah.
Okay. All right. Thank you for that. So then what about someone who just chose B? Why didn't you choose A and why did you only choose B? Do I have another volunteer? Okay. Well, let's go through them, shall we? So, Christina, thank you.
Sure. I say I selected B because of the difference between having a lower number of new cases, however, having a less survivor rate. So I thought that was an interesting, obviously, health disparity between the two.
Okay. So then why did you not choose A?
I didn't choose A because if it's a rare disease and the treatment just isn't available, I thought that that wasn't necessarily a disparity, maybe that there's just not treatment for it as opposed to having the treatment but not having access to it. That's how I interpreted A.
Okay, thank you for that. So yes, thank you so much. So you're right. I know that, and I know that I intentionally worded A in this way because I know that looking at, it's almost unfair, right? Why is it's unfair that it's this is unavailable, right? To the access point that was made earlier. But remember, when we talk about health disparities is a population health metric. So when we read a person, we already knew that couldn't be a disparity because this is an individual patient, right? And individual patients don't experience disparities. Only an entire population has to experience the disparities. And we're actually going to go over the populations that experience disparities. And so that was the first indication that this couldn't be a disparity. But to the point that was just raised, a rare blood disease is also not a social reason why they have this unfair, unnecessary outcome, right? It's a biological reason. Remember that this is a naturally occurring health difference. There's going to be naturally occurring health differences because of neurodiversity, because of, chromosomes and biology, right? There's just some things we just can't, there's nothing we can do. That's just the biology, right? Like you have this blood disease, it's rare, and that's just what it is. So for those reasons, it literally is a biological explanation for why they have the health difference, right? So it's inevitable. Now, again, it is, since it's rare to the point we just don't have a treatment, right? But it really is a health difference. Whereas B is an entire population being compared to an entire population. So we already know that. Now we're having a population health metric discussion, right? Instead of just individual patient outcomes. So yes, now we're talking about looking at groups and comparing them. If you think about the fact that, somebody could raise actually, what about the biological predisposition that white women have with the breast cancer gene? That's biological. Why is this one still an example of a health disparity? The reason is because even though there is a biological predisposition for white women with the breast cancer gene, they're more likely to get, that's the reason why they're more likely to get breast cancer, have a high incidence of it. But the thing is that we have lots of, advances in medicine where if you're screened early, then you can actually survive. And it's showing that a whole group that's more likely to get it is actually more likely to survive too. So why is it that a group who is less likely to get it is less likely to survive? That doesn't even make sense, right? And we know that there's no biological explanation for why Black women are dying from a breast cancer that they're less likely to get. The only explanation is social, right? And so remember, it's the social explanations are inequities. So again, bias, some of the things y'all talked about earlier, right? Again, not having the early detection, right? Not having the referral off to, by the time they find out it's aggressive, it's metastasized, it's spread, right? So that's most certainly. And again, even this last one, C, even though, yes, we're talking about population, skiers, non-skiers, the reason why this one doesn't qualify is because the one thing that I didn't know, and we're going to show you the next slide, is that health disparities, since there's only a social explanation, health disparities only exist in socially disadvantaged groups. So that goes back to reinforcing that it's a social reason why they have this. There's nothing, it's unnatural, right? So there's no social reason why the skiers have the long bone fractures. That's just inevitable because of the sport that you're engaged in. And if anything, that's not a socially disadvantaged group if you think about who skis, right? So for those reasons, the only answer would be B. So again, we think about what is at the root, right? What is the inequity? We have to move away from planning out and trying to design individual patient education, right? That is not going to address disparities. Because remember, disparities exist in an entire population. So that means that our interventions need to be structural, right? Because they're addressing structural inequity instead of individual, start doing this, stop doing that. That's just not going to address it. And we can look at the data. And that's why we haven't moved the needle, because we keep trying to use individual patient level education. We should be actually focusing on those macro issues that we know contribute to why entire groups of socially disadvantaged folks keep having poor outcomes. And it's those big, social issues. So if we think about in the United States, oftentimes you look through the literature, you will see that when we talk about, again, the unfair social outcomes, right, of these groups, we have a tendency to focus on racial and ethnically minoritized populations, right? And rightfully so, because, obviously racism is baked into the fabric of this country. And so ultimately we do see these unfair outcomes, by race. But we use the term disparity, but elsewhere in the world, they actually use the term inequality. And they're not focusing on racialized differences. They're focusing on, social, economic, or geographical. But nonetheless, it is these socially disadvantaged groups that they are assessing. And so the reason why the United States has a tendency to focus on the racialized ones was because of this report, right? You probably know this is a landmark report. This is really what put racialized disparities on the map because, it was kind of recognizing that like, okay, here's all these different patient populations. Why time and time again, all of the patients of color keep having poor outcomes, right? So this is the first time that we named racialized disparities in the unequal treatment document, which is like I said, to date, most of our disparities are racialized. But depending on your source, you may get a different take on what you should be assessing, right? The NIH teases out, health disparities only looking at epidemiological rates of like incidence, prevalence, right? And saying that's separate from not being able to access care, and that's separate from, health status, which is looking at like quality of life and, do you have pain and disability, right? So they really kind of tease it out and offer a more kind of comprehensive definition. But I will say that because there's so many different definitions, but I really gravitate towards the World Health Organization definition because it's very simple and straightforward and to the point, right? Like I've been saying, right? These are the health differences that just don't need to exist, right? Again, we know there's going to be some health differences because developmentally or biologically, you can explain those. But the other ones, the disparity that, these are the ones that are just avoidable. They're just unnecessary and they're unfair. So we know that this is why the only groups that experience them are the socially disadvantaged groups. So I want to walk through some principles to really kind of determine the best way for us to kind of frame our understanding of health disparities in an attempt to advance health equity. So as you can see, the very first kind of guiding principle when we talk about health equity is that we do really need to focus on the groups that fare the worst. Again, remember, health equity is about everybody having, a fair opportunity. But when you know that the socially disadvantaged groups, keep faring worse on every outcome, and again, it's no fault of their own. It's really just based in and rooted in discrimination and things like that. You actually have to address the gaps in those groups, or if you just attempt to do everyone is code term for the dominant group. And then ultimately you're going to maintain the gaps and even widen them if you don't focus on those who fare worse. So why do you suppose, that the definition of disability, when we think about the, ADA, the American Disabilities Act, why is the definition not, I'm sorry, I thought this was going to be a little more clear. It's kind of hard to read, but basically their definition is not a medical definition. It's actually a legal definition. Why do you suppose that that's the case? Let's look in the chat and see. Okay, more generalized to use a legal definition. Okay. Well, if we think about it, it goes back to what, it goes back to the socially disadvantaged groups, right? People who experience disability is considered one of those socially disadvantaged groups. So having a legal definition focuses on discrimination, right? Not having opportunities and, literally being unfairly treated, right? So that's why it's, the legal definition is more what is used when we think about ADA versus a medical one, because, it's kind of like, oh, here's a diagnosis, there are diagnoses, but we need protection, right? So that going back to this idea of inclusive care, and we want inclusive environments. So these are the socially disadvantaged groups, right? These are the groups that experience health disparities, okay? So you'll notice, and I want to be very clear, I'm going to point to I color coded this. We're going to go through the color codes, but in the blue group, it says people who are racial, ethnic, and sexual, they're minoritized, basically. I want to be very clear that even though there's a tendency to only think Black people, brown people are the ones that are socially disadvantaged, white people are socially disadvantaged too, right? Like all of the other groups could be white outside of racial and ethnic, right? So let's move away from this idea that social disadvantage is only racial, right? No. It is the racial people who are, minoritized racially, ethnically, sexually, all these other ways. And again, because we're intersectional, you don't just have one, identity. Then there's the confluence of like multiple, you can be disadvantaged in multiple ways, right? And so that, that's just how oppression works. But if we look at and I'm looking at the times, I see it because we're almost at time, so I'm just going to go through these, that the theme that all of the groups in red have in common, right? Not being health literate, being elderly, malnourished, minors, that these are all dependents. That's what they all have in common. So believe it or not, having a dependence on someone else is actually a form of social disadvantage. And so why? Someone else is determining where you live. Someone is determining when and if you eat and what you eat, right? Like all the decisions that are being made are by somebody else, right? So that in of itself is a form of social disadvantage. And that is why those in these groups would experience a disparity. And then you have those in the purple, right, who either are insured, but their insurance doesn't cover what they need, so they're underinsured, or they don't have any insurance, they're in poverty, they have a disability, they experiencing homelessness, right? These are groups that are often disenfranchised, right? When you think about the power and how power, kind of gets tapped and undermined for these particular populations. Those in the green are stigmatized. They're mentally unstable. They are system involved. What system? They could be incarcerated. They could be in the foster care, like any type of system. There's a stigma attached to those populations. And then all of the ones that you see in the blue, we already talked about being minoritized, but then you also can be undocumented. You can live in a rural area, urban area. You can, you don't speak, read, or write English, right? Asylum seeker. These are people and groups that are often overlooked. When policy is written, right, practices are upheld, these aren't groups that are considered, right? These are groups that are overlooked or silenced. They just are seen. They're not seen. Things are not designed with these populations in mind. And so that all of those are social reasons that disparities exist. These are the groups that experience it. So again, it's not, I want to be very clear. I mentioned the word power, and I don't want to imply that these groups don't have power. They absolutely do. If you think about social change around the world, social change comes from, marginalized groups, right? Whether we're talking about the Arab Spring or we're talking about civil rights, right? It doesn't matter. It's, so we know they have power. It's about, this idea of how power gets used and wielded, right? And again, how systems have been created and literally structurally engineered so that the poor outcomes that we see, like that, those aren't happenstance. We know that it happens intentionally. So when we think about, we want this inclusive care, we know that before we can think about being inclusive, we have to be diverse. And so we want our healthcare fields to be diverse. We want our research to be diverse, our research teams, our clinical practice to be diverse. And so, there are, these populations are, white, man or male, middle class, old or westernized, educated, heterosexual, Christian, able-bodied, English-speaking, American, and is that okay? Wait. Oh, wait, sorry. And what all of these populations have in common, these are what we call the dominant culture, right? They experience, unearned privilege, and these are hyper-visual. And we know that because the groups that you don't see here are the ones that are othered, right? This is the dominant group, and these are the groups that society is designed for. And all the other groups, we call those marginalized because they're literally pushed to the margins. We call them disadvantaged because these are the groups that experience advantage, right? So it's really important for us to understand that all of this has been socially created. There's nothing inherent about when we talk about disparities, we've created the outcomes that we're seeing. And this is why it's so important for us to think about diversity as representational diversity, right? It's not enough to just, think about, even like the NIH and different, efforts across the government says, we want, underrepresented groups. It's kind of like, well, these have been historically excluded groups, right? And we want to have that representational diversity in our programs and in our, clinical practice. And the thing is that sometimes the way that we're trained undermines that. So this is actually a screenshot of a Pearson textbook, a nursing textbook that has since been recalled because there was an outcry on Twitter, and Pearson has since issued a public apology, and they, pulled the textbook, but the damage has been done, right? This idea that, oh, we want you to be culturally competent, so this is what you need to know about. Basically, let me go back. Every patient group except white. As you notice that, like, why isn't white people on here, right? Like, there's nothing. So this just goes back to the point that I was making. Well, that's the dominant group, right? When we say patient, we mean white. And then everybody else, right? Now we can say, okay, what is their difference? And we put them in these groups, and then, it basically becomes this kind of slippery slope of pathology that gets attacked. Okay, but just what you need to know about Arabs, is you need to know about Black people, is you know about people who are Native American, right? And so in an attempt, right, it's almost kind of intent versus impact. And our intent was, but I was trying to understand, culture, and we know that there's a role of culture. Absolutely, we're not disputing that. What we're saying is that when we actually, attempt to understand it and flatten it in this way, we maintain stereotypes, right? And we don't see the complexity and fullness of patient populations when we do that. And so this is why it's really important for us to think about, again, distributive justice, right? Again, counseling and education, all those things are so important, but, it really doesn't move the needle for population health. And so that is why we have to really explicitly focus on health equity, or we're not doing health equity, right? So, again, equity is not the same as equality. And, and the thing is that I absolutely love this visual representation of understanding what equity is. I'm just doing a quick time check. Okay. And the reason is because in the usual graphics, you focus on the groups. And in this graphic, you immediately focus on the condition, that the foundation is uneven, right? So some populations have had generational head starts, and other populations will be perpetually playing catch up. And that's what this is showing. So we have the diversity, right? We got the different groups, but it's not about the groups, right? These aren't people issues. These are policy issues. So when we see that, the reason why some groups need to be more than others is not because they're inherently deficient, right? It's because, like I said, we have created the conditions they live in that they can't thrive in. It's not possible because they have increasing barriers, which is what the fence represents, right? We all got barriers, right? Sometimes we like to play oppression Olympics, but what about my struggle? We struggle too. You're right, we all struggle. But we're saying the most marginalized, disenfranchised, historically excluded group has more struggles, which is why the barriers is that much higher for the group, that is for that uneven playing field. And I love that the Robert Wood Johnson Foundation came out with an even newer graphic. And this one shows how equity benefits everyone, right? When you have the curb cut, originally you were thinking about the most disadvantaged group. And in this case, in this example, it happens to be people who are, have a disability, right? But when you do the curb cut, you add the audio, even though you were thinking about that group, everybody else is benefiting too, right? Because what you don't see is like the UPS FedEx person with their dolly. How did they get off the curb before, right? They struggled. Person with a stroller, they had to have somebody help them put the, so there was like all these other groups with the suitcase really bags, like all of these other groups that was still struggling. They figured out a way to do it, right? But when you thought about the least, advantaged group, and now you removed the barrier for them, there was a domino effect. There's so many other groups that benefited. And that's why it's helpful for us to think about equity in that way, right? Not just in city planning, like in this, but even in our clinical practice, in our research, in our programs, right? Because the opportunities for health, really do extend beyond healthcare, right? Just thinking about Park RX. I don't know if you ever heard of this, but it's giving prescriptions to parks to literally be out in nature. And so these are those, the social determinants. And as you can see, healthcare, which is so important, right? We need to have available clinicians and, cultural responsiveness and all the things, but there's so many other factors that are weighing on our health outcomes. And the good news for those of you who actually are clinically trained, that there are ICD-10 codes where you can bill for your time, right? So it's kind of like you take the time to really talk about housing situation that the patient is going through, or, food access. That time can be, billed. And because they, we know that it's super important, like these are the structural drivers that are really impacting that. And we recognize that it's more than just you as clinicians, right? Or social workers or community health workers, whatever role you have. It really is an all hands on deck approach, right? Which is why the CDC has a health in all policies. It's just not up to the Department of Health. We realize that whether we're talking about food access, we're talking about, housing, literally there's a health implication in, like the housing administration should be caring about health, and, schools should be caring about health, literally in every segment of our lives, right? And if we think about specifically, and I really love how Healthy People 2030 really has like a lens to look at some of those kind of socially disadvantaged groups, including those who are sexually, and gender minoritized groups. Really thinking about, we have to have important training, but we also have to have the data. We need to collect sexual orientation and gender identities, SOGI data. Because we only know what we measure. So that's like really important. And I'm about to end on this note. When we have this discussion on health equity, we need to move away from only focusing on gaps and lack and the data that focuses on the disparity alone. We really have to really hone in on what works. What are the wins, right? What are the resources and the strengths within our neighborhoods? Because again, that creates pathology for these socially disadvantaged groups when we're always talking about lack and need and gaps. And so there's so many ways to have an asset-based community development model, and that appreciative inquiry was what I was saying. You can talk about the wins and the lessons learned, and people learn and they gain from that. So, even like a local example, because I live in DC, we think about food access and there's all these food deserts and we don't have the big box grocery stores. It's like, okay, you know what, community members and business owners came together and said, you know what, what we do have, going from an asset-based community development approach, we have brick and mortar buildings, right? These corner stores, we have so many of them. And so when was the last time you thought of a corner store as an asset? Well, we have so many of them. Why wouldn't it be an asset? Yes, we're going to build on that asset, and we're going to talk to the owners. We're going to have these, farmers partner, and then like the Capital Area Food Bank and DC Central Kitchen, like DC Greens, partner with these healthy, corner stores and create what's called healthy corner stores. And that's literally what you see with the little yellow dots. Is that's an example of a community-led driven, process to address, one of the gaps in food access. So we know that a lot of these solutions actually exist in the community. So we won't have time to go through this. I think we're exactly at time. Are we at time yet? Yes, we're at time. So let's see what questions you have.